Hello and welcome to this month's Simon Says Expert series. I'm Shadia Jalal. I'm an associate professor of medicine and the Lawrence H. Einhorn Scholar in Oncology at the IU School of Medicine and the Cancer Center. November is Lung Cancer Awareness Month. We therefore think it is great to sneak this Simon Says session in before the month comes to an end. As a physician that has taken care of many lung cancer patients, there is no doubt it can have a devastating impact on the lives of patients and families. And while the treatment options for lung cancer have improved significantly, it is very important to try to diagnose lung cancer as early as possible to have the best outcomes. The good news is we can screen for lung cancer to find it in its earliest and most treatable stages. In today's Simon Says session, Dr. Ceppa and Sears are going to discuss the current state of lung cancer screening, the challenges to its implementation, and the opportunities for improving and expanding lung cancer screening. Dr. Sears is a pulmonologist and physician scientist at the Cancer Center who is focused on improving early lung cancer development and detection. Her research interest is on the role of DNA damage in the treatment of smoking-related lung cancer. Dr. Ceppa is a thoracic surgeon and a physician scientist at the Cancer Center. Her clinical focus is on general thoracic surgery, thoracic surgical oncology, and minimally invasive surgery. Her research interests include lung cancer screening outcomes and tobacco cessation counseling. They're both experts in lung cancer screening, and they are both my friends. And with that, we will start. Dr. Ceppa, take it away.
Well, thank you for the invitation. Let me share my screen real quickly. And once again, thanks for the invitation to speak about lung cancer screening, which is a topic that is dear to all of our hearts. And as you know, every year the American Cancer Society publishes their estimates of the rates of different various cancers in the US. And as depicted in this image, the number one cause for lung cancer related deaths is lung cancer in both men and women, with about 69,000 men predicted to die of lung cancer this year, and about 61,000 women to die of lung cancer this year in the United States alone. Just to give you a little bit of perspective as to what this means, the capacity of the Colt Stadium is about 67,000 people. And so predicted this year in 2022, there will be about 3.5 times this number of patients diagnosed with lung cancer, and about 2 stadiums full of patients dying of lung cancer this year. And so this is a slide that depicts, this is from the Sears data, the lung cancer prognosis, based on their stage, the lung cancer, the percentage of patients being diagnosed at various stages. And as you can see, patients who are diagnosed with localized or regional lung cancer only represent about 40% of patients. And the vast majority, or over 55% of patients, are being diagnosed with stage 4 disease. This is a slide that goes over 5-year survival rates based on the stage of which patients are diagnosed. And as you can see here, the overall of all comers, all patients diagnosed with lung cancer, 5-year survival rate is abysmal at 22.9%. However, it is much better for patients who are diagnosed earlier. For instance, in patients who are diagnosed with stage 4 disease, their 5-year survival rate is about 7%. And for patients who are being diagnosed with localized disease, their 5-year survival rate is 61%. And it's even better for patients who are diagnosed with smaller tumors. So the opportunity for us to have the biggest impact on improving the lung cancer survival is by diagnosing more early stage disease. And that's where the National Lung Screening Trial comes into play, right? So in this study, patients who were deemed high risk for developing lung cancer, namely patients between the ages of 55 and 74 years old, either current smokers or former smokers who quit less than 15 years ago, they had to smoke 30 pack years or greater. So the number of packs per day smoked times the number of years smoked. And they were randomized to either screening with low-dose CT or with chest x-rays. And they enrolled about 53,000 patients. And what they found, and this is a table from the manuscript, but what they found was the same number of patients were diagnosed with lung cancer in both the low-dose CT cohort as the chest X-ray cohort. So about 1,000 patients per group were identified as having lung cancer. However, in the cohort of patients who were screened by CT, 50% of the patients diagnosed with lung cancer were diagnosed at either stage 1A or 1B. In comparison, about 50% of patients in the chest X-ray cohort were diagnosed at either stage 3B or 4. And so overall, what the study found was that screening with low-dose CT for lung cancer resulted in a 20% reduction in lung cancer-specific mortality and a 6.7% overall reduction of overall mortality, and that's because of incidental findings from screening. So this table summarizes the landmark papers on lung screening. We just reviewed the National Lung Screening Trial. The Nelson trial was conducted in the Netherlands and Belgium and was initiated in 2000. They recruited both current and former smokers, ages 50 to 75 years old. Other eligibility criteria including a smoking history of either 15 cigarettes per day or greater for more than 25 years, or 10 cigarettes per day for over 30 years. CT imaging was conducted at 1, 2, and 2.5 year intervals and was compared to usual care. And in this study, screening with low-dose CT resulted in a 26% reduction in lung cancer-specific mortality after 10 years of screening. The MILD study, or the multicentric Italian lung detection study, was launched in 2005. The study randomized about 4,000 patients who were screened with low-dose CT versus control arm of no intervention. Participants were 49 to 75 years old. They were current smokers or if they quit then less than 10 years ago, and had a smoking history of at least 20 pack years. And then those who were randomized to low-dose CT were then further randomized to receive their screening on either an annual basis or every 24 months. At 5 years, there was a significant difference in the cumulative incidence of lung cancer identified between the control group and the low-dose CT participants, but no difference in cancer incidence between the patients who were screened at every year versus every other year. Lung cancer mortality did not differ among the groups, nor did the mortality, overall mortality differ between the groups at 5 years. However, at 10 years, there was a 39% decrease in lung cancer specific mortality and a 20% decrease in overall mortality. So this slide is a timeline of all the events related to lung cancer screening over the last 20 years. I wanted to highlight 2011, which is when the National Lung Screening Trial results were published. And it took 2 years later before the U.S. Services Preventive Task Force actually provided a grade B recommendation in support of lung cancer screening. And it took another 2 years before CMS actually agreed to reimburse for lung cancer screening. The European trials were published in 2018 and 2019, and it wasn't until recently, so 2021 for USPS task force and 2022 for CMS, before the criteria actually extended to beyond the National Lung Screening Trial criteria. This is a table of the lung screening and criteria, and this is before the extended criteria, so this is the initial criteria. Basically, they were National Lung Screening Trial criteria, but what I wanted to point out is amongst the various organizations, the USPS Task Force, CMS, there are differences, right? So USPS Task Force agreed or supported screening patients up to 80 years old, where CMS would only reimburse for patients up to 77 years old. And then yet the National Comprehensive Cancer Network supporting screening for patients who also had less extended criteria. This table represents the current guidelines, which, as I mentioned before, are somewhat extended. So a younger age threshold, so patients who are 50 years old or greater. And the threshold for smoking criteria was also decreased from 30 pack years to 20. And once again, National Comprehensive Cancer Center Network also added a secondary criteria of additional risk factors. Now, it's not surprising that with all this mixed messaging with different organizations supporting different criteria, that the adoption of lung cancer screening has been stunted. So in this study published in JAMA Oncology, the authors demonstrated that lung screening frequency did not change even after the USPS task force provided their grade B recommendation in support of lung screening in 2013. Additionally, it was noted that over 50% of smokers meeting eligibility criteria were either uninsured or Medicaid insured, which we'll go into that aspect of Medicaid insurance in a couple of slides. Now, in a more recent study of Medicare patients published in CHEST, it was determined that of patients who were eligible for lung screening as demonstrated by the map on the left, only 4.1% of lung screening eligible Medicare patients were actually being screened, as represented by the map on the right. So the deeper and darker the intensity, the higher the number of patients. And as you can see, the map on the right is much lighter gray than the one on the left.
So, Dr. Ceppa, clearly there must be a lot of challenges. Could you cover some of the barriers of why adoption of screening is so low?
Sure thing. So, the adoption of lung cancer screening, the barriers to it are multifactorial. First, there are provider factors like just lack of awareness of the guidelines. And then there's the fact that some providers don't even believe the data. So, when lung screening first started, the American Academy of Family Physicians put out a statement that they felt that there wasn't sufficient data to support lung screening. And this only recently changed in April 2021. And then there's the fact that lung screening is just labor intensive, to be quite honest.
What does that mean? Explain that a little bit, please.
Sure. So, here I list the CMS criteria for lung screening. And as you can see in the center is the patient, as it always should be, right? Now, CMS has specific requirements for the facilities, meaning they are like American College of Radiology specific requirements, standardization of nodule identification and reporting. And then data, initially when lung screening was started, there was a requirement that data had to be collected and submitted to a CMS approved registry. That has since been removed. But then there's, of course, the eligibility criteria, which we just talked about. And then the ordering physician, or now APP, ordering physician extender, has specific requirements, namely the documentation and very clear documentation in the order, as well as in a clinic note of the fact that the patient meets criteria. But then there also needs to be documentation of a shared decision-making visit, whereupon the risk, the benefits, the percentage, the likelihood of identifying a cancer versus not, the likelihood of having some an unnecessary procedure, it needs to be documented and discussed with the patients, specifically with the use of a risk assessment tool. And then there are radiology specific requirements, meaning the radiologist has to be board certified, which is not surprising, but then also has to have read at least an X amount of CT scans in the last several years. And then they also have to be up to date on their CME, et cetera. So all of this is quite cumbersome if you think about it. And none of these requirements are imposed upon other modalities of screening like mammography or colonoscopy.
So I think I'll take this next part. There are provider factors that Dr. Ceppa has highlighted very well. But there are also patient-specific factors that are challenging to lung cancer screening. As Dr. Ceppa has clearly outlined, the criteria for screening are not incredibly clear, right? And it depends on your payer status, where you're getting screened and what criteria they're using. So while there's, I think, a general lack of awareness of the guidelines in the public, those that are aware of lung cancer screening may not know whether they even fit criteria. I think particularly with some of our most vulnerable patients, there's mistrust in the healthcare system, and I think that can't be understated. I think something that doesn't get a lot of discussion is access and costs. Access to lung cancer screening, not all facilities offer lung cancer screening. Lung cancer screening is a program. It is not a low-dose CT scan. And so while a lot of places can do low-dose CTs, they cannot necessarily do lung cancer screening in a programmatic way that makes sure that you get the mortality benefit that we've seen in the studies. So I'll show you a slide in my talk where we discuss that. But I also think that we should talk a little bit about cost, because lung cancer screening is covered by most insurances and CMS, but some insurances require pre-authorizations. And if you are not in a program that is really well established and used to doing this, it could end up with patients being billed initially, even if it ends up getting written off in the end. And I think that goes back to mistrust and misconcerns. And then, of course, there's the stigma of smoking as well.
So actually, Dr. Sears, one of our listeners did ask about stigma. What does that mean, and how is it playing a critical role in this?
Yeah, and thanks for letting us know the question in advance. I have here just I could go on, this could be a talk in and of itself, but I think most of us listening to this would recognize that cigarette smoking itself has a stigma, and associated with it, because it's a major risk factor along with age of lung cancer patients face a really unique stigma compared to other cancer patients. I included data here from the 2018 Canadian Lung Association survey, where they specifically asked patients with and without lung cancer about stigma. And you can see 76% of patients with lung cancer felt stigmatized simply from having lung cancer. And the two on the right are particularly concerning for me as a physician who cares for these patients. 42% of those patients felt they were less deserving of help, and 45% put off going to the doctor because of self-blame. And I really think that highlights, in particular, this perception that lung cancer patients somehow did it to themselves, right? And you might say, well, that's just perception. That's just those patients' feelings. But if you can click Dr. Ceppa, in that same survey of all respondents, 15% said those who smoke deserve lung cancer. Now, take a minute to let that sink in, because as someone who cares for lung cancer patients, that's incredibly disturbing. Not only because it, first of all, no one deserves cancer, period. Secondly, there are plenty of diseases, plenty of people who get lung cancer that are never smokers or minimal smokers or have quit smoking. And thirdly, because there are plenty of other poor health habits that are associated with other cancers. But no one would say this about somebody who has those cancers, right? So, I don't think this is just a perception. It's very real. And this study I included below by Dr. Carter Harris, who used to be here at IU and did this as a part of the lung cancer screening program here, along with Dr. Ceppa, you can see is also on the study, looked at specific patients undergoing lung cancer screening and what they perceived to be potential barriers. And along with inconvenience, which we can understand, distrust in the healthcare system, which we associated with, the number two that came up was perceived smoking-related stigma. And these are things that specific patients said, that they feel misunderstood by younger healthcare providers. So they just don't understand the culture that they grew up in. That there was a lot of blame and feeling like a social outcast, that if they go to get screened, they'll make them feel like an idiot or feel stupid for smoking. So I think this is something that has to be addressed with lung cancer screening, regardless, and by every provider that's encountering patients for that.
And then, of course, another layer of barriers to lung screening is systems factors. So as I mentioned earlier in the talk, 50% of patients who are eligible for lung screening were either uninsured or Medicaid insured. Unfortunately, Medicaid doesn't cover lung screening in many states, as indicated in this map by any of the orange hexagons. Then, of course, there's the issue of geographic access. So this map demonstrates distance to the closest lung screening facility with an increasing or darker color representing an increasing distance. So the magenta color represents a distance of 150 to 200 miles, while the burgundy represents a distance of more than 200 miles from the closest screening facility. And of course, unfortunately, there are inherent health disparities within our current healthcare system. And this study, which was published by the Journal of American College of Radiology, demonstrated that patients who are uninsured those who had an education level lower than high school, and those who were Medicaid insured had decreased access to lung screening facilities. Now, we also know, on the other hand, that there are ethnic and racial differences in the risk of lung cancer, smoking-related lung cancer. So in the study, investigators sent out surveys to adults 45 to 75 years old living in Hawaii and California between 1993 and 1996. And they linked the survey responses to Sears and National Death Index data from their respective states. The risk of lung cancer among ethnic groups were then modified by the number of cigarettes smoked per day. And what they found were that at greater than 30 cigarettes per day, there was no difference. However, among participants who smoked no more than 10 cigarettes, those who smoked from 11 to 20 cigarettes per day, and those who smoked no more than 30 cigarettes per day, African Americans and Native Hawaiians had significantly greater risk of lung cancer than did the other groups. And the differences in risk associated with smoking were observed among both men and women, and for all histologic types of lung cancer. Now, In this study, which was published by JAMA Oncology in 2019, a cohort of about 48,000 patients were observed for 12 years. And what they found was that under the current, which was the 2019 US Preventive Services Task Force guidelines, lung cancers were being missed in high-risk populations, namely those in rural or low-resource urban areas, minority groups, patients who were socially and economically disadvantaged, and of course, those with other high-risk exposures, like exposures to secondary agents like radon, secondhand smoke, and other high-risk groups, such as those with EGFR mutations. What we also know is that there's disparities in follow-up of patients who have already undergone lung cancer screening. So in this study, 14,000 patients with a positive lung screening exam were followed. And logistic regression determined that gender, marital status, race, and smoking status were predictors of follow-up, in that men, people who were single, divorced, or widowed, current smokers, and Black patients had significantly lower follow-up rates, even though they already had a positive lung screening exam.
All right.
Thank you, Dr. Ceppa. That was great. So Dr. Sears is going to go over some of the local challenges that we face in Indiana and some of our future directions, hopefully, to improve lung cancer screening uptake.
Okay. And can you see my slides?
Yes.
Perfect. All right. So some of these are local challenges that Dr. Ceppa and myself see. And then I want to talk a little bit about where I see future directions for lung cancer screening. And I'm going to try to go through this fairly quickly so we have some time for additional questions from the audience. Dr. Ceppa showed you kind of the global data for at least the United States, but lung cancer screening is a challenge everywhere, but particularly here in Indiana. So on the left, you can see that we are the orange in both of these graphs, and the national average is green. So we have more lung cancer than the average for the United States. We are 44th in lung cancer diagnosis, largely driven by a higher than average cigarette smoking rate in Indiana. However, you can see we're a little better than average. We're number 20th in lung cancer screening. We're in the average tier. You can see that orange there, and better than the national average. But I would also draw your attention to the y-axis. We are currently screening 7% of eligible patients in the state of Indiana. So this is really quite low. It's low across the board, but particularly for us. So we need to do better. So how can we do that? And of course, we always talk about low-hanging fruit, but I think we have to think about the whole picture here, how we can improve what we're doing currently to improve lung cancer screening as well as survival for our patients, as well as then thinking about screening eligibility and equity, up to newer advances like imaging and molecular biomarkers, and finally, how to implement this on a larger level. And I'm going to talk more about our state, but obviously in the long run, this is looking beyond state and to at least our country and beyond that. So thinking about tobacco treatment, this is a necessary part of all lung cancer screening shared decision-making visits. It's required. But what I want to point out is that we've talked already that lung cancer screening implementation is quite low. And this is included in this graph here, which compares lung cancer screening to cervical cancer screening, breast cancer screening, and colorectal screening over time. However, I would argue that this isn't just because we're bad at lung cancer screening. We've talked already about several of those barriers, but I think that, again, cigarette smoking comes into play here. You need a lot of information to be able to get lung cancer screening. And we don't do the same thing with these other screening tests. I hope your care provider is a good care provider and asks you some of these questions, but hopefully doesn't ask you how many sexual partners you've had before you go ahead and are approved for cervical cancer screening. It's just not a requirement, right? I think we have to keep that in mind as we're doing lung cancer screening, that while it is really important and we shouldn't forget about the risk of cigarette smoking and screening, I think if we screen all people without being able to refine it better, we'll not be able to sustain that. But, and we may cause more harm than good in some patients, but I think we have to address tobacco use in a very non-judgmental way and make it easier and more streamlined to include in our screening processes. The other flip side of that is that we can use the fact that these patients going through are either former smokers or current smokers as a real opportunity. And the fact is that lung cancer screening is a teachable moment for cigarette smokers. When they reanalyzed the NLST data, which again showed a 20% relative reduction in death due to lung cancer, that increased to 38% in the population of patients undergoing lung cancer screening who were able to quit smoking cigarettes. So this is a huge change in and of itself, not to mention looking at the additional benefits that you may get down the road in things like heart disease and stroke. Additionally, we know that having a nodule identified on a screening scan, which is really common, okay? So at least a third, and in some studies up to 60% of patients undergoing lung cancer screening have some sort of nodule identified on it that needs some sort of follow-up. Only 4% of those end up being cancer, according to the NLST. But those with a nodule on screening scan that's identified as concerning are more likely to quit smoking. So another time when we can discuss with them, hey, I think it's really time that we discuss cigarette smoking. And the reality is that bringing it up is enough, right? We don't have to wait until people are completely ready to quit. And there's data out there that patients who were asked if they were willing to quit or wanted to consider quitting, and then were given therapy with varenicline, or Chantix is the trade name, were twice as likely to quit smoking than those in whom we waited to quit smoking. So that's a really big opportunity there. I'm going to touch on adherence. I know Dr. Ceppa already talked about some of this, but adherence is a real problem. In one study, yearly compliance is really low. It's about 50% by year 2. So if half of our patients are not coming back, and most of the stage 1 lung cancers actually are caught after the initial scan, right? That first low-dose CT scan may catch more cancers, but not necessarily early stage, right? So we get the stage shift towards years 2, 3, 4, and beyond. But if patients aren't coming back, we really can't catch these lung cancers early. So this is a big deal. We already know some people who are more likely to be compliant. Dr. Ceppa already told you women and those who are suburban is one. We know that if you're older, you have a concerning nodule. If you have a dedicated program coordinator, and I'll show you some of that in active reminders, and if you're a former smoker compared to a current smoker, you're more likely to come back for your next scans, okay? And we talked about some of these system barriers and patient barriers already, but I think when we're talking about coming back for lung cancer screening, those barriers are still there, right? They were there initially getting them in the door, and they still need to be addressed with getting them back. And there are some additional barriers too, like need for patient tracking to be able to tell that patient, hey, you're a year out, it's time to get your scans again. So it really highlights the need for dedication to having systems and resources available to get these patients in and to get them back. And just to highlight that, this was a study that was published in 2019 by Lucy Spaluto, who looked at a screening program that was in the community. And you can see here that line is when they implemented a program coordinator. So they were doing screening kind of on their own, and they were getting about 20% adherence to follow up. And as soon as they hired a coordinator and had them actually following patients and making sure they got follow-up, that adherence went up to 70%. So that's a really big deal. Additionally, here we go. Additionally, if you look at this study, this is looking at the use of reminders, and it really doesn't matter who does the reminder. A primary care provider or a nurse navigator for a lung cancer screening program were used in this study by Dr. Hirsch. But the reality is that if you had someone reminding you, you had somewhere between a 60 to 80% likelihood of them coming back. If they didn't get a reminder, 0, okay? 0 in this study. So we really need to be making sure that patients are coming back. Understand that this is not just a CT scan, that this is actually a program, and to get the benefits, you have to come back yearly or when required to get follow-up. So how can we improve adherence? We've talked about some of the systems related issues, reinforce that lung cancer screening is more than a one-time scan, have processes in place to make sure that we can identify those patients that return. And I would argue that we should have systems in place to maybe focus on those at the highest risk for falling out, those with poor resources, who are in the rural areas, who are maybe younger, current smokers, et cetera. All right, so focusing on screening eligibility and equity, as Dr. Ceppa pointed out, we're not all equal, and there are other ways too. This is the state of Indiana that I'm including here, and you know, I put in the blue squares those lung cancer screening programs that are centers of excellence through the GO2 Foundation. This is a not-for-profit that basically makes sure that you can do lung cancer screening and are following the results, have everything needed then to treat that patient. So you can see those, and then in blue, a very similar program through the American College of Radiology that makes sure that these are programs in the blue squares that can basically do all of that, have a very robust lung cancer screening program. In the gray are identified centers through the American College of Radiology that have the capacity to do lung cancer screening through low-dose CT scans, but not necessarily all of the resources to have a very robust lung cancer screening program. Even including those, I hope you can appreciate that if you are a person living in rural Indiana, which is all of the, you know, kind of greenish, I think it shows up gray color, or the pink, very rural areas in Indiana, it's likely that you don't have a lung cancer screening program near you, and you're going to have to travel quite a distance to do that. So, you know, there are ways to get around that. I think ideally you get more programs and you get more collaborations. People have used buses to bus out there, similar to what they've done with mammography. But right now we're just not, it's just not equal if you're rural. The second thing I want to bring up is the use of risk assessment models to improve lung cancer screening. So right now, Dr. Ceppa basically showed you the criteria, which are very much based on age and cigarette smoking. But we know other things are associated with development of lung cancer. So there are a number of models which have all been validated in lung cancer cohorts that improve risk assessment in lung cancer. I've listed several of these here. And every one of these I've listed on this table have been applied to lung cancer screening and improve the determination of those at high risk of lung cancer compared to the U.S. Preventative Services Task Force recommendations. So, you know, there is a role for potentially using a risk assessment tool to determine who needs to be screened and who doesn't. This is an example of an ongoing study, the International Lung Screening Trial, which is based in Canada, Australia, Hong Kong, and Spain. They are recruiting patients using the PLCO M2012, which gives you a 6-year cumulative risk of lung cancer. And if your risk of lung cancer over those 6 years is greater than 1.5%, you fit. You either get randomized to that versus the U.S. Preventative Services Task Force recommendations. And I believe those were the prior recommendations, the 2013. They then compare the lung cancer mortality as well as lung cancers diagnosed. And so we will see what ends up panning out from this. But in the interim results, it looks like more lung cancers were identified through the PLCO M2012 risk stratification. There were more low-dose CT scans performed. So again, we will have to see how that pans out. Use of biomarkers. So this is an area that's rapidly changing. And of course, as you know, a biomarker is anything that can identify lung cancers early. So there are two different types of biomarkers. One, which I will focus on, which can detect early lung cancer prior to getting a CT scan, so that we know those patients who are at the highest risk to then go on and get lung cancer screening. Additionally, there are biomarkers that are being developed to better identify which pulmonary nodules, as I said, that pulmonary nodules are very commonly found on low-dose CT scans for lung cancer screening, but to identify which pulmonary nodules are more likely to be cancer and therefore need more aggressive evaluation compared to those less likely to be lung cancer, which could be followed with serial CT scans or other radiologic follow-up. These are some biomarkers that have been specifically applied to lung cancer screening. In particular, 2 of these have been evaluated in larger clinical studies of clinical utility, including Notify CDT, which was done in the UK. They didn't follow out long enough to see whether there was a survival benefit, but they did show a stage shift with more early stage lung cancers identified, and those that were identified as high risk by this Notify CDT. And then the MSC signature, which I'm going to go into more detail on, which just wrapped up in Italy. So you heard about the MILD trial by Dr. Ceppa. So this is BioMILD. This was applying the biomarker to those going through lung cancer screening. And you can see that they all got an initial low-dose CT scan. These were patients at high risk, similar to our current our prior criteria with high cigarette smoking history. So these all got a low-dose CT scan. And if the low-dose CT scan was positive, they still checked your what's called an MSC score here, and either had it reported as positive or negative, but basically based off of the CT characteristics and the nodule characteristics, they had a 3-month or a 1-year follow-up. However, if your low-dose CT scan didn't show any concerning nodules, they basically checked this MSC, it's a microRNA panel, to see if you were at higher risk for lung cancer, in which they got another CT scan in a year, or if you were at lower risk, in which case they got a CT scan in 3 years. Okay, so trying to space out screening. They had a reasonable number of lung cancers at about almost 3% of patients. And you can see, as Dr. Ceppa pointed out earlier, the majority of these were diagnosed as stage 1. What you can see here on the right is that when you had a positive CT scan and the positive MSC score, you were more likely to have cancer. If you had a positive CT scan in general and you had a concerning nodule, it was more likely to be cancer. That makes sense. But what you can see here is that if you had a negative CT and you had a high risk of cancer by the MSC score, continuing to follow you every year, still you had low number of cancers, but you were able to detect some cancers. And on these scans, what you can see is that if you continue to detect those yearly in those that had a positive MSC, you were able to detect more cancers, but didn't have an increased mortality. Similarly, if you continued with current lung cancer screening, you can see that, except for those that were diagnosed on the very first scan, your mortality was all pretty low, right? That's this bottom B study, showing that you could actually have a lung cancer screening algorithm in which some people who are at higher risk get screened more frequently, and those at lower risk actually get screened less frequently, making this less labor intensive and making it less risky, or still not risky, but less labor intensive for the patient as well. All right, the last thing I want to touch on with this portion of it is radiomics. So this is a hugely growing area in which now that we have CT scans and computer capability to do deep learning on thousands and thousands of low-dose CTs, they're able to actually pick out characteristics of pulmonary nodules that are more likely or less likely to be cancer. So this can actually aid in not just detecting nodules, especially those that we've all seen nodules that are near the certain structures in the lungs that are a little bit more difficult to pick up by the naked eye, but also tell you whether those are more or less likely to be concerning. And this was just a study using the Loomis radiomics platform, in which they compared the ability of the Loomis radiomics platform at identifying nodules compared to a radiologist. And what they found is that this did just about as well as radiologists, not just in picking up the nodules, but as on the right, you can see here, modeling the likelihood of cancer. So it was able to pick up pretty similarly to our radiologists, and in some cases even better, whether a nodule was likely to be cancer or not, and therefore should be flagged for follow-up. So I suspect that in the coming years, we're going to see more and more radiomics being integrated into general pulmonary detection, but in particular in lung cancer screening, where that is how we find these concerning nodules early on. And then finally, I just want to point on improved advocacy and implementation. The first thing is I'm going to point out a couple myths, right? So myth one, lung cancer screening costs too much. I put here on the left the number needed to screen to prevent one death. And if you screen someone for 3 years, it's 320. That's very similar to breast cancer and colon cancer. And if somebody goes through lung cancer screening for 10 years, it's even lower, at only 130 patients needing to be screened to prevent one lung cancer death, which is much better than a lot of other screening studies that are currently implemented. The second is on the right, also from Canada, which because they are a country much more open about the costs, it costs them about $450 per lung cancer screening in that there. And you can see that their costs for surgical resection of a stage 1 lung cancer at $33,300, or for stage 4 lung cancer at $48,000. I can tell you that's much lower than the average cost in the United States for stage 4 lung cancer. If you consider 10 years of screening at $450, you are right about where you would treat one patient with stage 4 lung cancer. So if we can diagnose these earlier, we will save money, okay? So that is definitely a myth. The second thing, the myth, we can't make it work on a statewide level. All right, so I'm an IU fan. I was born here, I'm a Hoosier. Every time IU plays Kentucky, I think you can know just by me telling you that who I want to win. But I have to say that I'd love to see us kind of equal to Kentucky and having a good game when it comes to lung cancer screening. But unfortunately, right now it looks more like this, okay? Which makes me want to cry, but this is why. So yeah, really Kentucky has the highest rate of new lung cancer cases in the country. This is them in the orange all the way here to the right in the bottom tier. So we beat them there, okay? But with screening, we are doing really poorly. This is us again in the blue, and Kentucky is in the orange. They are in the top tier for lung cancer screening, okay? So how did this happen? And the reality is that Kentucky just made it a priority. It was a combination of universities getting grants, partnering with community providers that were committed to lung cancer screening, and then their state getting interested in saying this should be a major public health issue for us. We need to put resources into lung cancer screening. I will tell you, if you go onto their website, you get pictures like this one on the right, state resources, where you pick a county and it tells you where you can get screened, what the data is, how many lung cancers are being prevented. This is insanely good, right? And they've bought into it. If you go online, this is one of their, but I have already quit. Even if you've quit smoking, you can still get lung cancer. This is a copy of one of their billboards. If you smoked, this new lung cancer screening could save your life. It's all over the place in Kentucky. And the reality is that they just signed into law a new law that basically makes lung cancer screening under the Kentucky Department of Health, meaning that it gets individualized funds. They have to track lung cancer screening. They have to track how many cancers are diagnosed. And then they provide that information. And they have an expert panel that makes sure this is being done right. So, I think Indiana can actually learn something from Kentucky in this case, as much as it pains me to say. All right. So we are trying to do some things here. This is In Lung Cancer Now, which is an initiative through Indiana University, partnering with other partners throughout our state, including corporate sponsors, to end lung cancer at all stages, but with a particular focus that I'm interested in, which is improving lung cancer screening along with prevention and research. I will point out that we are the next state to be included in the American Cancer Society lung cancer echo project, which you can see here. Kentucky already did. It was one of the 3 pilot sites, something else that helped to kind of catapult them past the already good job they were doing into doing even better. So hopefully next year we will be a part of that. I've already signed on to help because I think this is really important. And hopefully with this support, we'll be able to kind of help to do things on not just an individual hospital and healthcare system level, but also with the state level as well. So I'm going to end there and move it to Dr. Jalal for any additional questions that have come up.
Thank you, Dr. Sears and Dr. Ceppa. That was great. Okay, so let me ask a question. So let's assume I have a history of smoking, and I now know that I should get a lung cancer. I should enroll in a lung cancer screening program. Okay, so what do? Do I go to my primary care doctor to order my scan? Can anybody order it for me? How does it work? Obviously, we talked about the shared decision process, right? And that kind of stuff. But what would be the next step? What would I do as a patient?
Well, you can do any of the above actually at IU Health. So if you went to your primary care physician, they could put in an order and or send in a referral to the IU Health Lung Screening Program. And then that initially launches, we do this eligibility criteria screening. So the schedulers will screen the patient to make sure they meet criteria and confirm that first before they even schedule the appointment. And when they schedule the appointment, they also schedule an appointment concurrently with our lung screening APPs, who then perform the shared decision-making visit right before the scan is performed. Now, patients can also self-refer. They can call the radiology or our 1-800-lung hotline, which is lung screening hotline. And similarly, they'll get the radiology folks, scheduling folks will go through the screening criteria and get confirmed for an appointment, and we'll meet with the APP for the shared decision-making visit.
Got it. Okay.
I would add that if you are not near one of our screening programs, so I run the screening program at our local VA, which we are expanding to the entire state of Indiana, but you have to get here, right? So that remains a problem. And I think it remains very difficult for patients to know which facilities, there's been a lot of confusion. Places will put out, for instance, come get a $49 CT scan, right? That's not a screening program. And the hard thing is, you know what you know, right? And you don't know what you don't know. So I would say, number one, don't leave your primary care providers out of the loop. I would definitely loop them in that you want to be screened, because they will probably know the local, what is available locally, okay? And then the second is that if they don't, go online. There are tons of resources through the American College of Radiology and the GO2 Foundation are two of those that actually will link you directly to programs that provide lung cancer screening. So, that's kind of the short answer. The other thing is that it's not available everywhere, right? And so if it's not, I would tell your provider, listen, are you doing lung cancer screening? Who's doing it? And, it's better than nothing, right? So find a program if you can. You're going to get the best results because they're going to make sure they do this in a protocolized fashion, that you get the next treatment, that things are reviewed. But I also think that if you can't, ask your primary provider, how can I get lung cancer screening? Who do I need to talk to? Where do I need to go? And go from there.
So another question, it's a question we actually got from the audience. So, the National Lung Cancer Screening Trial did it for 3 years, right? Low dose for 3 years. Now, I assume this is more or less a lifelong thing. And as long as you qualify in that criteria, and obviously as long as you qualify for screening, right? So you wouldn't screen somebody that is less likely to die from lung cancer and more likely to die from a major heart attack or a stroke, or they have severe COPD and they're on 7 liters oxygen or things like that. So I guess the question is, how many years do you screen eligible patients? Do you just keep going every year? Every year it's that discussion with your primary care physician. Do I still qualify? Or is it you hit 75 and you stop screening? Or I would argue you would still screen a healthy 75, 76, 77-year-old guy or woman, obviously.
So the first point I want to reiterate, which Dr. Sears has already made, is you need to screen at a program. It is not a one and done. It's never been a one and done. It's not,
right.
You do have to come back for repeated scans because that's where the benefit really comes from. And to answer the question of how many years, it's not just like the lung screening trial did only for 3 years, obviously, because they had to end the study at some point.
Right.
However, it is for as long as you meet eligibility criteria. So, that could be for 10 years, it could be for 15. And once again, it depends on, the eligibility criteria. And as you mentioned, there's no point in screening for lung cancer if you're not fit enough, medically fit enough to undergo treatment. right? So you do need to be a patient who can undergo treatment, whether it's SBRT or surgery or chemo, but you do need to, it would make the most sense basically to screen only patients who, regardless of age or gender, right, who can actually undergo treatment.
Yeah, and this, I think there's still questions on when to end it, but I will also say, because we live in a world where if you're paying for things yourself, it's very expensive, right? So if you have CMS coverage, the answer is they will stop paying after you're 77 years old. And if you have commercial insurance, typically it follows U.S. Preventive Services Task Force recommendations. So that ends at 80 years old. And if you have quit smoking for more than 15 years, congratulations, you have dropped your likelihood of lung cancer to the point where most studies would say that you're probably at higher risk to continue screening than to stop. So you do not fit the criteria for lung cancer screening at that point anymore.
We have a new question, which is, since lung cancers are inflammatory diseases, do you consider using immune cells as biomarkers for lung cancer screening?
Ooh, that's a great question. So there are some, I didn't go into a lot of the biomarkers. You can tell I'm a little geeky with this, but there are a lot of different biomarkers, including some that include autoimmune, both proteins as well as antibody-related markers in bloodstream as well as in other fluids. There are some that look at the level of inflammatory markers, as well as some that look at a ratio. So I'm thinking of one now that is available. The Notify XL2 actually is a ratio of a protein that is elevated in cancers compared to a protein that's elevated in inflammatory markers. So it looks at the ratio of the two. So and autoantibodies to cancers are included in a number of the protein biomarker panels that are available, and several of these are commercially available. Now, none of them have shown clinical utility yet, so we don't know if they change practice, but we do know that they can predict lung cancer. So yes, that is, thinking from discovery all the way through. There's literally thousands that are in the discovery phase as well. So I can't speak as much to that because there are so many of them, but yes, that is being considered.
So whenever we say the word screening, I always think that hand in hand goes with it the word anxiety, right? And that's just, from personal experience, right? When I'm about to get a mammogram, I'm not the happiest person in town kind of deal. So I guess my question is, how much do we think anxiety plays a role into things? Who should be having that conversation? Should we explain to patients so they come back for that next scan that there's a really good chance there'll be something on your scan? You live in Indiana, there's granulomatous disease and things like that. But more than likely, it would be nothing, for example. You might get a call, don't be scared. Are we good at doing that? Is anxiety potentially one of the reasons why people don't get a scan in the first place, don't come back for a scan in the second place?
Yes, I think the answer is yes. So there are studies that have looked at anxiety with lung cancer screening, and there definitely is an increase in anxiety in some of the patients that undergo screening. There is an increase in anxiety when a nodule is found. And some of these studies, mostly qualitative studies that have looked at kind of directly interviewing patients, have found that, mixed results. So sometimes bringing it up to them ahead of time or putting it in study materials will help with some patients. With some patients, it just doesn't. Mm-hmm. And so I think, having that reassurance that you're a part of a program, we're reviewing everything, and we will let you know whether anything else needs to be done, and we will let your primary care providers know you're in good hands, is really important. But I think it also goes back to that fatalism with lung cancer, right? That a lot of these patients already have a fatalistic point of view. Well, I've smoked cigarettes for this many years. Something's going to happen. I'll probably die of lung cancer anyway. And I think we just need to go beyond that and say, and acknowledge it and say, okay, I understand what you're saying, but we have proof now that's not true. So let's get beyond it and let's let's focus on what we can do to help you at this point. So yes, there is anxiety, and I think it plays into that. How exactly to address it, other than just continuing reassurance that the majority of these nodules will not be cancer, but if they are, that we are in a program. This program provides the structure to be able to deal with those quickly, and to be able to deal with them effectively, so that if this is cancer, we're getting you the appropriate treatment is really important.
So I have one final question. Dr. Ceppa, go ahead, please.
No, I was just going to reiterate the point. The whole point of lung screening is to catch this at a stage where it's curable, right? And so that is, if nothing else, that should help at least deal, or at least manage the anxiety a little bit. So even if we were in the rare chance that we find something, we're finding it at a stage where it's curable.
Mm-hmm. So, obviously we've lived through the pandemic, and, there's a lot of bad in the pandemic. But the question is, could we somehow use some of the things that we did in the COVID-19 vaccine and all of that stuff, and kind of use that for lung cancer screening? So for example, instead of ourshot.in.gov, could there be ourscan.in.gov, where you click, there's a score, if you qualify or not, you click, you see the closest place close to you. Could you have a virtual visit with somebody that is, far from you, right? Where you do that decision shared process virtually and potentially be able to get a scan and follow up. Could we be creative? Do you guys see any of these as potential solutions to improve lung cancer screening in Indiana, especially in some of the rural areas?
So I would say 100% we could be creative, but what it does take is a consortium, right? So not to go back to the Kentucky idea, but they were able to get such high screening rates because they collaborated, they worked together, and they all had the same mission, right? So it is possible, and we at IU Health we do virtual visits to make it a little bit simpler and whatnot, but it requires a very big collaborative group, and it involves a lot of, I would say, administrative and systemic efforts, right? But I might be biased. I think it's worth the effort, right? And I'm sure Dr. Sears feels exactly the same way.
Yeah, we're putting you on that echo panel, whether you want to be or not. We do virtual visits as well. I think a lot of those things you talked about, make anything that makes it easier and less stigma related, right? So you meet criteria, great. Let's just go get you screened. And the reality is we find other things on lung cancer screening. So maybe we shouldn't call it lung cancer screening. Maybe we should just call it lung screening, because we are just as likely to find a nodule in your thyroid. We found kidney cancers. We found a lot of other things, interstitial lung disease early on that needs to be treated. So, get your lungs checked out, get them screened. And I think all of these are great suggestions.
Well, Dr. Sears and Ceppa, I think I have learned a ton about lung cancer screening as a lung cancer doctor, and I hope people come see you guys so that they don't see me as much. That was a great session. Thank you all for joining us for this month's Simon Says. Next month, we'll hear from experts at the Komen Tissue Bank at the IU Simon Comprehensive Cancer Center. Till then, be well.
Bye, everyone.